So, good morning, everyone. As usual, we are presenting that I think this is the 43rd session on the challenging case series. Today, the second case is a very interesting case. I think I'm seeing for the first time. But the first case, as usual, is a short one. So, shall we? I will share the screen now. Okay, this is the story of a 56-year-old man who presented with numbness of left little finger, which later on affected the right little finger and middle finger 6 months back. Now, what he said is correct. 56-year-old man presented with the numbness of the left little finger, which later on affected the left ring finger and middle finger 6 months back. 2 months later, his right hand got affected in the same fashion, affected the first little finger, then the ring and the middle finger. But mainly it was confined to the little finger. There was no weakness or any other complaint. This is Dr. Lovin examining the patient. The right side and pointing with the same fingers on the right side. Biceps normal. It was normal. He had mild weakness of the inversion of the left side. Compared to the right, less on the left side. Suspicious weakness of the region 2 block on the lateral one extensor longness normal. Exopolis is very normal. So the TNMS is not affected. The right side everything was normal. This polis is normal. Exopolis is very normal. The finger is also normal on the right side. There is a weakness on the left side, not on the right side. Finger extensions were normal. No formal sign was observed. Reflexes upper reflexes were well elicited, normally elicited. Biceps normal. Supinated normally elicited. Biceps also normal. Finger pressures also well elicitable bilateral. Near angle checks are all normal. Sensation, he had impaired pain over the little finger on both hands. He's telling it is better on the index compared to the little finger. Pain on the right side as well. It was impaired on the little finger. He's pointing that area where it's numb. This is better on the index finger. We compared lateral medial aspect of the ring finger, there was no difference. It's same. Same here also. Medial and lateral side of the ring finger was normal. Joint sense to the thumb was normal. But index finger, little finger was impaired. He said he could not say what went directly. He said he does not know. Similarly, in the right finger also he made mistake. He made mistake there. He said it does not know. Our vibration was normally elicited on both initial finger. He could appreciate normally that. One was not. So on examination, tone normal in both upper and lower limbs. Power, mild weakness in Indonesia on the left side. Questionable, I think there is weakness of finger flexors of the middle two fingers on the left. Rest of the muscles were normal. PTR, upper and lower limb normal, well elicited finger flexion bilaterally. Plantar flexor. Sensory impaired pain over both little fingers. No difference in the pain appreciation between the medial and lateral side of the ring finger. Impaired joint sense of both little fingers. However, vibration was normal in those fingers. Gait is normal. So, where is the localization? What is the possible diagnosis?
Sir, cervical, sir.
Yeah, please.
Sir, cervical myelopathy, sir, because it's early ischemic myelopathy.
Cervical myelopathy. Why can't be ulnar palsy bilaterally?
Finger flexion seems to be brisk, sir.
But ulnar palsy may not affect the finger flexion.
Patchy involvement.
It's not patchy. Sensory loss is confined to the middle little finger.
Only Indocious and APB is not affected.
APB will not be affected, no? In ulnar.
And not adductor pollicis is not affected. Formal signs is normal.
But we need not get all muscles to be affected equally in any nerve palsy.
Yes, sir.
So the possibility ulnar palsy, CA radiculopathy, intermedullary lesion, CA D1 spinal cord level, none of the above. Okay. So what you said is correct. But you have seen such cases before. It's for other people that may not be aware. The NC is normal. This showed this is something like a pancake enhancement, which is you find a disclesion, mild disclesion, but an intermedullary ischemic changes inside the cord. There is ischemia or demyelination, we don't know. Whatever it is, the cord lesion is causing the sensory loss. The point why many people may not be aware that the first thing in high cervical myelopathy to occur may be paresthesia of the medial two fingers. That in the middle finger. Sometimes may extend up to the medial forearm. One may erroneously initially suspect bilateral ulnar palsy. But if you get bilaterally occurring, you have to always think that you may be dealing with high cervical cord compression. Here, the only clue was finger pressure difference, which we often would not examine it also. Otherwise, there is subtle weakness in the interossei and the numbness in the middle two fingers. The numbness is very prominent in this patient, and the joint sense impairment. In fact, even pain may not be there. Pain loss may not be there. Only thing may be impaired JPS sensation in the little finger. So always carefully look for impaired JPS in the little finger in a suspected case of paresthesia in the middle hand. That's the thing which this kind of person we have seen many cases before also, but hardly ever stressed in literature. Any questions in that case?
Good morning, sir. Sir, is there any finger escape sign on the little finger?
Nothing in this patient. It's only finding was sensory was the dominant thing. He had no combined weakness.
And in this case, where do you lock? I mean, isn't this cervical cord? But is there any?
No, this can occur anywhere above this. It's not at the D1 level. It is above that. Maybe even the CT. The usual finding is it is C3, C4 is a compression. Here it is lower down, but it can be even as high as C3, C4. That is so this sensory loss is due to the involvement of the posterior cord. Yeah, please.
What was the treatment of it?
You submit. In fact, he advised since his disability was very mild, he was advised only cervical column. We thought we'll wait and follow up the patient before submitting for surgery.
Sir, what is the cause of the pancake appearance?
No, there are two postulate. One is the ischemia, second is the demyelination causing it.
And what's the criteria for surgery in these cases? Is it the lesion or the physical disability or something?
No, always it should be the physical disability, not the extent of lesion. Suppose if you submit the patient for surgery, because whatever has happened inside the cord may not reverse. Okay, so only thing we can prevent further progression. So in that case, we can try. I have seen people in myelopathy improving cervical collar alone if we continue to wear it without surgery. Those who are not willing for surgery, they come walking after some time. So that means that these changes in the cord need not necessarily indicate irreversibility, but can sometimes it may be suggestive of a sinister prognosis. Okay, I'll go to the next case. You can see the hyperdensity within the cord. The compression is not much, you see that. Here, if you do the surgery, it may not benefit you much. Only thing is to prevent the further flexion extension movement in the cervical spine. That is going to produce more harm. Okay, next is a very interesting case. This case was referred to me by Dr. Lovin George from Toduvida. He was our PG student when when he was there studying in Pushperi Medical College. This is a story of a 43-year-old man. He presented with a history of inability to keep his hand elevated for a long time for the last 6 years. For the last 2 years, he noticed difficulty in pouring water from a cup the usual way. What he's telling is that when you want pour a cup like this, it gets tilted. You cannot hold in the correct position. It gets tilted. It gets tilted. Can take it normally in the below. When it takes it up, it gets tilted. For the last 6 months, he needed support of it. So initially, he was using his support of the right hand lift up his left upper limb. Whenever it gets tired, he needed support of his right upper limb to lift his left upper limb. But now, for the last 3 months, he found difficulty in elevating his right upper limb as well. This he found out that he could not elevate his left upper limb on his own, but he could elevate his right upper limb on his own, but was unable to lift his left upper limb with the help of the right hand, which he was used to do before. Initially, he was elevating the left hand with the help of right hand. Now he found that he could not do that. That is why he detected that right hand upper limb is also affected in way. Otherwise, he can lift it on his own. Like that, he can no problem. So, this is the experiment. When he tries to keep his hand holding it, straight like that against cavity for some time. Then it comes to not like that. Examination because he called for something. Forcing him, he can hold his hand. And again, what's again? Okay. So there is an examination reflexes were all normal, rest of the muscle power was normal, and there is apparent weakness left deltoid. He could hold it for some time. PTR all normal, sense system normal. What will you consider at this point of time?
Neuromuscular to be considered metabolic myopathy to be considered.
Metabolic myopathy, yes.
Neuromuscular.
Left
Due to the left upper limb.
lumps.
Lumps possibility, okay. Right. Was it functional? Could it be functional or myasthenia-like thing?
Yeah, it can be functions.
And, okay.
It is not functional. It's not functional because he's symptomatic and he has been suffering for the past many years. And the way he holds that's only like a neuromuscular.
So you think something of a myasthenic syndrome. Of course, myasthenic syndrome possibility. But don't you think it's remaining localized to one upper limb alone for 6 years is slightly odd?
Yeah, sure.
Yeah. There's
Myotonia.
no myotonia in this patient.
Okay. Function should be considered higher calcium.
Okay. I couldn't hear you, Parmeshan.
Functional thing to be considered at the higher list also, sir.
Now, one of the possibility can be considered, but you have to examine him in detail. Okay.
Yes, sir. Yes,
So what do you want to do? RNS?
sir.
In fact, this RNS I did only for only confusion later on. So RNS is normal. No decrement in left trapezius. On the CMAP amplitude is also normal.
Yes, even test, sir.
Let us see the next part of the examination after undress. So we hardly undress the patient examine, but you always do make it a point. When he is undressed, he found he has got a wasting of the left deltoid. So started examining detail. Get weakness in the left deltoid.
ചിലപ്പം പറ്റും അല്ലേ ചിലപ്പം പറ്റും പിടിച്ചോ പിടി 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 ആ
Biceps was normal.
പിടിച്ചു
Biceps normal.
രണ്ട് ചെയ്യുന്നുണ്ട്
Then micro brachial is normal.
ഓക്കെ
Ingression is normal.
രണ്ട് മടക്കിയിട്ട്
Peak concepts are normal.
ഇങ്ങനെ ഇരിക്കണം
And rotate
അടുപ്പിക്കാൻ
on the
സമ്മതിക്കും
right side, on the left side.
ഇതെങ്ങനെ ഇരിക്കണം അടുപ്പിക്കാൻ സമ്മതിക്കും
That is
അതാണ് അകത്തോട്ട് പിടിച്ച്
And rotate is normal.
ഇങ്ങനെ അടുപ്പിച്ച് വെക്കണം കേട്ടോ
That is major version. One wasting of the infraspinate is there. Just one thing to look at.
ഞാൻ കയ്യിൻ്റെ വഴി കയ്യിലോട്ട് തള്ളും
It external rotates once again. First not external. First right.
ഇത് എൻ്റെ കയ്യിലോട്ട് ഇങ്ങനെ
The
തള്ളണം
check is but more.
കണ്ടു പിടിച്ചോ
You get it. But left side. Yes. When I ask them, "Hey, keep it in that thing."
30 ഡിഗ്രീസ് പിടിക്കണം പിടിച്ച് നിർത്തിക്കണം
Keep it right side. Left side. I can eat the connection of it.
നിർത്തിക്കാൻ
It's a small amount.
തലയൊന്ന് പൊക്കിക്കുക
People say name.
അങ്ങനെ പൊക്കിക്കുക
Power of the 17 mark.
മുട്ട് മടക്കിക്ക്
Sensation is normal. This is a long case, okay? Right. So on examination, wasting of the left deltoid, supra and infraspinatus. Weakness of the deltoid, weakness of the same muscles are also observed. Pectoral is normal, pressure of the muscles normal, DT are all normal, sensation is normal. So where is the site of lesion in this patient now?
Brachial plexus.
Brachial plexus made like a little more specific. Let other people also answer, no? And let the people. What is the site of? monomelic anticonvulsive disease, good possibility, right? Anything else? Can be upper trunk of brachial plexus, C5, C6 radiculopathy. Can be a muscle disease. Because if a facial scapular musculoskeletal can be also asymmetrical also.
Looks like a nerve lesion, sir. Upper part of the brachial plexus.
Yeah, could be, but there is no sensory.
Or
But that may not be there all the time. Because
with
there
the
are,
nerve entry, like the supra spinatus nerve compression by a ganglion cyst,
yeah,
and
but,
axillary nerve involvement by adjacent shoulder lesion.
yeah, but the problem here is the both nerves are affected, axillary and supraspinatus. The both are at different location. That's a problem. If we are near the upper trunk supraclavicular area, we expect the other muscles separate with the upper trunk like biceps, etc., to be involved, which is not involved here. So a possibility, but there are some conditions like neurologic amyotrophy can present selective involvement of nerves, deltoid and supraspinous, very well taken. That's a condition. So upper trunk of patchy involvement of the upper trunk is a possibility, like a neurologic amyotrophy, which can pick up nerves. May not involve the whole trunk or full. Okay. So is it left SCFS is good? Possible, because we may not get, it's mild weakness only, may not get weakness of the rhomboidus, we may not get weakness of the serratus to differentiate between the all that time. Left upper thing is a possibility. Yeah, anyone else you want to make a comment?
Sir, this left C5 here brachioradialis is strong, sir. It's not weak, no, sir.
Yeah, correct. What you said is perfectly right. See, it's not, brachioradialis is not weak, biceps is not weak, but the point is that the affected muscles can go with that. See, we do not know tomorrow biceps is going to get weak.
Okay, sir.
If it is significant weakness, say for example, grade 1 or 2 power of the above muscle sparing on the biceps, okay, it is totally against. But initial phase, some of the muscles may not be that strongly affected. That possibility you have to keep in mind. Only keep the possibility. Like anti-console possibility, which you thought is also a good possibility. The only point is that in anti-console, it fits in with the nerve pattern. That's the only thing. That was segmental pattern. And an anti-console disease confined only to the upper limb for 6 years remaining, or unless you think of something like a Hemi-masticatory type of disease, which usually log site is little lower, as you all seen. Then could it be myopathy? It's also you have to keep in mind. I have seen FSH person like a foot drop. I'll present you next week another case.
For 6 years, will it be like that, asymmetrical?
Yeah, it can be very asymmetrical. But on examination, you find some findings opposite side, but can be very asymmetrical. But that's also unlikely point. There's no weakness on existing on the other side, even though combines of the weak. He combines the weak right separately, but then clinically I could not get any weakness. Okay, what do you want now?
Sir, is there any patch of sensory loss on the upper lateral arm?
In fact, I checked it. I did not show it to you. There is no patch of sensory loss over the lower arm. In fact, I got another video which can show that, because for the interest of time, I did not show it. It is not there.
An MRI of the region, sir.
Okay, we'll take an MRI. First, we did a conduction. We find what you found was there is a decreased amplitude from the left axillary deltoid, and the suprascapular nerve stimulation. From the outside report, it was decreased from the supraspinatus. I don't know supra-infraspinatus. It is decreased supraspinatus. Sensory were all normal. So, but we don't get a sensory involvement, even upper tongue involvement, because only nerve which can look for is a muscular-cutaneous, which was not looked for. So that possibility can't be totally ruled out at this point of time. So decrease EMAP from the left deltoid and supraspinatus, normal snap. In fact, I did repeated the nerve conduction to be from the infraspinatus also. We show same finding as before. It's got decreased amplitude in the deltoid and from the infraspinatus. Sensory was not affected. Then the EMG was done from the left deltoid to find out rule out a myopathic process or neuropathic process. Those elements of innovation from the left. Then it from the supraspinatus, again showing evidence of chronic dementia. Then left FTA was done, which is normal. So it is not affecting the other muscles in the body. FTA is normal. Then coming to the right, during the right deltoid, I wanted to know whether that was affected. Right deltoid also. Only delivered, no actually. Right FTA normal. EMG showed the denervation from both deltoid and left infraspinatus. No denervation in the distal muscles of the upper limb. So that means some loss of axon or entity constant in those area is the one which you have to consider in this patient. No apparent sensor. Okay, this is the conclusion now. Now, what is your diagnosis? Now the myopathy is out. Neuropathy becomes less likely because sensory potential is not there in this patient. But the possibility of neurologic hemiatrophy cannot be ruled out. But it's progressive over 6 years. That's all. So MRI was done. This MRI done from outside came with this MRI. Look at the MRI very carefully. You find the CSF collection anterior to the dura here. And there is a long hyperdensity within the cord in the region of anterior. Okay. Again, you can make it with more lateral cut. You can see that this is the dura. This is CSF collection anterior. This again the dura. This again another cut. Now, this is the again axial cut showing that this is the dura. This is CSF collection externally anteriorly. But it was not in the upper part, in the CV junction or the C1, C2 level, it was not there. The C3, lower part of the C2 downwards, the anterior CSF collection can be seen. Again, C3, C4 level, you can see the collection. And at the level of C3 and C4, C5, you can see hyperdensity in the anterior cell. That corresponds to our weakness also. That's a CSF collection anterior. This is C7, C8 also it is there. And they came with the contrast. You see the contrast showed enhancing lesion here anteriorly in the dura. Here and posteriorly also it's enhancing. Normally we don't expect enhancement here. But unfortunately, the T1 weighted sequence was not provided from the outside. This is the axial cut again showing the enhancement surrounding the extradural space. But however symmetrically present. So long extradural CSF collection from C4 downwards and anti-frontal hyperdensity was seen. An MRI brain done on outside was normal limits. So this is the report from the outside. Long column of T2 hyperintensity and T1 hypointensity in the spinal canal anteriorly, extending from C3 vertebral inferior to T2 vertebral level, likely present prominent CSF space. Thin hyperintensity in the cord, probably syrinx. Then find impression, column of T2 hyperintensity, anterior hyperintensity in the spinal canal, anteriorly extending thoracic lumbar region with abdominal enhancement. No compression of the cord or focal membrane enhancement. At present problem in CSS piece. So what is the diagnosis now?
So is it a trapped CSF with ischemia?
Sir, an old hematoma which has compressed the cord and led to focal anterior horn cell death.
But in the see the signal changes was that of the CSF. Exactly like a CSF.
Then it has to be because of a dural leak, dural tear. There is leak of CSF in the spinal canal.
That's the thing. But you find abnormal enhancing lesion top.
Yes, it has got infected.
Then what is that thing? The enhancing is the upper part, above the level of that extradural CSF function. So let us see the films once again. This is from outside. Let us see. We repeated the MRI here in our hospital. Same one, and you find this is the dura, and there is a small disc abutting the dura here, which may not, it may be insignificant. We don't know whether it's really causing any problem. Anyway, the CSF is collecting outside the dura here, longitudinally. Okay. Now let us see that another cut again, same as before, brought from outside. Again, the CSF collection anteriorly extending down. Again, you can find the dura getting separated from anteriorly.
That's the tear there in the previous image.
Pardon?
Single sleeve, sir.
The previous image, sir. Cervical section.
Yeah.
T2. That tear there. No, the next one. That's it.
I'll show the film. Don't worry. I'll go to show the other film which we have taken repeatedly.
This one.
No, I'll show it in more detail. So the axial as a cervical spine, this is the T2. I'll show this is the uppermost one. Now it started appearing the CSF collection. You can see the dura and the CSF collection. Again, you can find the CSF collection. Now this is which is a little more clear than the before. Again, going down, I can see the anterior contractile hyperintensity here at this level, C3, C4 level, C4, C5 level. Then hyperintensity CSF collection continues down. Now, this is the interesting. Everyone has picked up external CSF collection. But what was an enhancing lesion? See, this is so if we take a T1. The T1, there is no hyperintensity there. I'll show the one more film. But there is some, at some area, see, there is some hyperdensity, not seen here. In the T1, this is T1. You can see that one. Again, you can find hyperdensity there. So we did a contrast that area is showing enhancement. Again, that's showing in just like the previous one.
Your trauma was there in the patient.
Okay, once again. So this is axial cut at that level. See the enhancement, this is the cord, this is a not space, this is the dura. The enhancement is seen outside the dura.
Post contrast.
Then this is I kept both the things simultaneously, corresponding level, both the plane, this is the plane area, this is the contrast. Okay. That area is showing enhancement. MRI brain was done to find out that it's normal, except that also the enhancement of the dura, it was not there.
The history of trauma was there at any point in time.
No, it's just trauma, I think. There is some suspicion of increase the size of the lateral sinus, but that what we are not very much convinced about it. But here it is.
So is it a perimedullary leak and SIH?
It's a dural leak, dural tear, and therefore leak in the.
But what is the enhancing lesion? That's the problem. There is suspicion of some enhancement, increase the size, but not very much convinced.
So is it something like a spontaneous spinal hypotension with a perimedullary leak?
But what is the person enhancing? So let's
Sir, is it engorged vascular spaces?
engorged.
Vascular spaces, vessels.
Sir,
Yeah.
engorged vessels, sir.
Correct, perfectly right. So
Dural elevation.
yeah. So spinal pachymeningeal enhancement and nodular enhancement of the anti-spinal during C1, C2 level. Enhanced can be extending all around the spinal dura, even extending through the spinal column. So initially, when I saw it was only the anterior, I did not see the horizontal axial cut. I was wondering whether it's the granular pachymeningitis causing this enhancement, because it is something like a bulging out into this thing. But seeing the axial, one can be certain that it is not, because it is symmetrical, uniform, surrounding the extradural space, extending into the foramen. Now,
Sir,
seeing,
I have a doubt.
yeah, yeah,
Sir,
please.
there is a dural tear, there is a CSF leak, but there is no intracranial hypotension. It's only focal cord compression with anterior horn cell. Why is there no intracranial hypotension?
Exactly, you are exactly right. That's the thing I'm coming down to. Okay, coming down to this case. There is no evidence of intracranial hypotension. That's why we took everything, the MRI brain sequence out, not say anything. Now let us see. Let us see. So the history to go back, went back, and why he's got hypotension. So he has any complaint of any. He denied any headache at all at any time. But repeatedly asking, he said he used to get aching pain on the back of the neck and expanding to the back of the neck and back of the thoracic region. This used to occur while sitting. Then he asked him, then he was not bothered about it. And he used to see his mobile phone in the lying position, which he found comfortable, because the aching pain was much less while lying. And this was on leading question. He never volunteered this complaint. Now, what are the possibilities? Idiopathic pachymeningitis, benign randomness. This is initially we thought, none of the above. See the Phillips ones. No, you see the horizontal. See the axial cut, the cervical axial cut. See, this is the all around symmetric lesion cannot occur with the granulomatosis lesion like that. Very, very unlikely. You can be extending into the foramina outside. This is the corresponding contraction that you two showing that this is the area which is enhancing. You can find the forwards here anteriorly. This is the one enhancing. You can see the forwards here. That means they are the dilated venous plexus. Again, the corresponding cut going through that, showing that enhancement. Another cut. No dishes neura, seen the spinal dural dilated venous plexus. So, spinal pachymeningeal enhancement and enlarged dural venous plexus with enhancement. That is the finding here. So that these two tells you that this patient has got a intraspinal or intracranial hypotension. But here it is not intracranial, but a spinal CSF hypotension. Okay, right? And the CSF pressure is low, intraspinal hypotension. That means there is a leak somewhere causing the extradural correction. Okay. You also said leak, but where is the leak? You have to
Actually,
In one of the sagittal MRIs that you showed, just
Yeah.
below the enhancement, there was a break in the dura.
No, that's difficult to find out on that film. No, I'll tell you how we bend the head like that. You got a point, but that's not a break there. I'll come to that. So what's CSF collection? So what's it? Spontaneous intracranial hypotension? No evidence of intracranial hypotension, but there is evidence of intraspinal hypotension. as suggested by dilated venous plexus. Without dilatation, the intracranial venous sinus. That's the point you have to keep in mind. Now comes what caused the intracranial hypertension. Was there a tear anywhere? So the ideal sequence to find out the tear is a 6 sequence, where you can find out the CSF can be the structure within the CSF can be made it very clearly. So we have got extradural CSF, then intradural CSF, then you can make out the tear correctly. So we did the entire spine sequence. This is cis or the cervical region. I go by one, going downward. Again going downward from the cranium downward, coming down. That's the CSF appearing there. The dura is here. You say, no, the dura is here. So with thoracic now, thoracic also there is extradural CSF production going down and deviate. Then the next level, lower thoracic, you can see somewhere there. Remember, this is 48% nearly. The subarachnoid space is now did the lumbar region. This is on the freeze cut showing that this is the dura, this thoracic level at the extradural CSF. This is the lumbar one. Okay, outside the dura, this is the caudate and roots appearing. You can see the CSF production anterior. Then go to the next level, lowermost level. You can for the sacral meter. This you can find out. This is the cut you taken here. You can see the this dura and the CSF anterior. So from C3 downwards up to the lower sacral region, that's a CSF collection anterior to the dura. But the dura is all seen that there is no tear in between seen there. But a small tear you can't pick up from any investigations. You can do a myelogram, contrast myelogram to find out the leak. Then only you can pick out this thing but we don't have facility for that in our institute. So then what we did was then the question was, is there any tear? So what caused it? So we found out, was this causing any? This is the dura. This is abutting the dura here. So what we had a doubt whether that is causing it. So we did and was there a calcified spur there which can be missed in the MRI. A calcification in the spur getting into the dura can tear the dura and produce leak. So we did a CT scan again at that level. We find out any calcified spur abutting the dura. There was no calcified spur at all. We are back to square one. Then thought whether it's a dynamic compression from that a small disc may be compressing the dura anterior by flexion movement as you find some kind of pyramidal disease. So we did a repeat the MRI once again in the neutral and flexed position of the neck. This is a flexed position, but again there was no abutting of the disc on the dura. This is a flexed plane. It's a normal position, that's a flexed one. Again, there is no change or a dural compression on the flexed plane. So there is no dynamic compression. Then we have to find out the source, see a source the leak somewhere, then only we can give any blood patch or anything for this patient to prevent further hypertension occurring. So let's see the C sequence of cervical spine once again. I will show the C sequence, which I already shown once. But at one point, that one point,
It's a split up.
actually, you can find there is something coming from the dura going
Split
inside. Okay, but that's not a calcification. But it's something there in the dura coming and touching into the coming inside.
It's black. So SWSC can.
Yeah, that's also blood. That means we thought it would be calcification. No, but I'll please get that level. Oops, sorry. I'll please. And this is the one we take the three-dimensional picture. This is a C2, C3 level that is above the level of the extradural connection. You find something jetting from the bone into the dura, but there's no calcification. The CT did not shed calcification. This you can again make it out there. You can again make out that the one which is compressing the dura there. Now, and then we took again, repeated the MRI once again. We want to know whether that is causing compression by flexing the position or something which is innocuous. So we did in the neutral and flexed position again in the sequence at that level once again. You find the CSS space become decreased on flexing in the flexed position here, as you can see here. It is less than what you see in the normal position. Again, in this cut also, it is less compared to the neutral position. Now, so we think that more likely there is a motion from the vertebral body compressing onto the dura at the C2, C3 junction level. Vertebral body or the disc space that is not picked up in the CT, so it's not calcified. Some of the ligamentous structure is jutting out and producing the dural tear. That is and the CSF collection is below that. That's a logical thinking which we can think in this patient. Now, then next question comes. What he came with amyotrophy, not for this collection and all. So we have to sort out what is causing this amyotrophy. Now, can this extradural CSF collection cause brachial amyotrophy? That's the next question to decide. Is there and you find a location exactly at the segment responsible for the wasting and weakness in this patient. That is C4, C5. You can make it very clearly there. And the anticonceptive that's only getting intense, hyper intense, and that to segment only. Unlike an occlusion where you get extensive interstitial hyperintensity. Yes?
It can cause, because cervical being the cord is a larger in size compared to the dorsal and next large will be the lumbar area.
Yeah, correct.
So actually, the CSF collection, whatever small is there, can compress the cord. Unlike in the dorsal, though it should be very large.
Correct. Exactly. That's one of the postulates.
Sir, I think during flexion, it is causing frequent compression at that particular location. So ischemia along with direct compression would lead to this.
Yeah, perfectly. That's what I showed you. That CSS space became narrowed on flexion. That's the postulate we also had. Then there is a ligamentous projection from the C2, C3 level into the dura, producing a compression leak there. And then CSF collection causing the ischemia is below that. CSF collection is causing the pressure effect and producing ischemia. But do you have literature evidence for that? Let us see. One thing is certain, it is the brachial amyotrophy is due to antecondylar lesion because of two things. The lesion corresponds with that, and the antecondylar hyperintensity is suggesting an antecondylar movement. Let us see the literature. This I think skip by the interest of time. Various types of tear and all. This is how the tear occurs. This is the dura. This is a calcified spur or a disc spur touching the dura and producing the leak. This is another type of CSF leak in the root sleeve. Sometimes this is a root sleeve tear here. Sometimes it can produce a CSF leak into the venous vein that is called the CSF venous fistula, or maybe outside the spinal canal can produce the dural. Now let us see the literature. There is this called ventral longitudinal intraspinal fluid collection. You remember this, in this whole extent, there was no fluid collection posterior to the dura. Only anteriorly it is present. This rare presentation of as brachial myelopathy in intracrinial hypertension. There is one case report here. Then presently there are 6 reports with 12 cases associated with brachial myelopathy with in the ventral longitudinal intraspinal fluid collection. And this case, I think, from your theory. Now, they were all confused as to what caused the brachial myelopathy. They postulated that maybe direct compression of the cord leading to antiphon cell loss was proposed by one author. Dr. Luca Etta reported 3 patients. He hypothesized a similar to Hirayama's disease. The amyotrophy could be consequence of dynamic pressure by the anterior cyst on the ventral cord, conduction block or the tethered motor route by the dorsal cord enhancement. That is other postulate, as someone has pointed out. Then this particular person postulated cervical antiphon cell involvement with secondary mechanical compression. The other postulate, Taylor and Burns postulated just like what we are thinking, that ischemia can due to the lower cervical antiphon cell. I got reason to believe there is no direct compression in a case of ischemia because this is confined only to the antiphon cell ischemia, and this antiphon cell is vulnerable to ischemia. And secondly, that segment alone is affected. Let me again then corresponding to the weakness. So we have got, and the clinical findings also pure motor weakness assisting the antiphon cell disease. So this is another in literature research. So this patient has, in short, has got a ventral longitudinal anterior extradural CSF collection, probably due to dural tear at C2, C3 level, producing dilated venous plexus and interspinal hypotension, and compression of the extradural CSF collection producing ischemia to the antiphon cells, presenting as brachial myelopathy.
Sir, why isn't he presenting with intracranial hypotension as well?
Yeah, your question is very valid. In fact, usually intracranial spontaneous intracranial hypotension, one of the postulated is the dural tear down below. Usually we expect that, but here it is confined only to in all this literature. That's why they coined the term ventral longitudinal extradural circulation spinal cord.
Because sir, when the CSF comes out, CSF from the brain also will come out. So it has to drag down.
Yeah, theoretically, you're perfectly right. Here also the venous sinus dilatation is only in the spinal canal. It's just external spinal canal, not intracranial.
Sir, does a spinal DSA would throw some light on the venous condition, sir?
No, but in fact, we have no doubt about that venous condition because that's literature and described literature, and no other lesion can produce such a uniform bilateral enhancement. I think it's typical venous sinus enhancement, no structural lesion, other mass lesion.
Maybe the CSF leak will be so insidious and so slow that
Correct.
it might not have produced. This is a long history of 6 years. So the leak would have been very, very minimal. And that would have compensated, and the patient did not have any features of intracranial hypotension.
Yeah, that's a good postulate. Yeah, I agree with you, Lindu. That's a good thing.
Sir, one doubt.
Okay.
Sir, is there any postulate like C5, C6 anterior horn cells are more susceptible to ischemia than this C8, T1 or something?
In the literature search, the other patient who just came, the Veeramani and all, he presented like Hirayama. He had the CA-D1 segment involvement. The same condition, ventral longitudinal extradural CSF collection. He presented with Hirayama's disease.
So comparing the anterior horn cells to the C5, C6 segment or C8, T1 segment, all are equally susceptible.
Yeah. In fact, sometimes some preferences for CA-D1 because of the, if it compresses antispinal artery, but here somehow it is causing the ischemia. That much we can say, but what is exact mechanism we do not know. It is a compression by the says compress only the sulcocompression artery. I don't know. With antispinal artery, it would have effect little more lower down. As you find the antispinal artery thrombosis, the extent the involvement of antispinal artery anticonception is much lower down. Now, I'll show a similar case. I'll run through this case. This again lends credence to the theory of ischemic anticonception disease. 60-year-old man, known case of hypertensive, presently came with severe burning. Recently is complained. Severe burning and aching pain from the back of the neck radiating down the spine for the last 3 months. He could not sleep due to the pain. He gave passes to 2 strokes, one 2 years back, another 1 year back. During the first episode, he had blurring of vision. I think forget about that, but he is not the present problem. But the second episode, he weakness the right side, and he's almost totally improved, except for mild hand weakness. But his complaint is not that. He has come with severe pain in the back. This is the patient.
ഇവിടെ നോക്കിക്കേ ഇവിടെ
Only mild hand weakness or the binding.
ഇപ്പോഴേ അറിഞ്ഞൂടാ ഇതും പറയണം
It's something like a binding cell summary, not normal in upper and lower limb. Weakness of the right hand, rest the power normal. DTR all on the brisk side in both upper limbs. In the lower limb, right knee jack was brisk, left knee and both ankle jacks were 1+. Plantar right upgoing, left ongoing. Sensory impaired joint cells were both little finger and both toes. Normal JPS on the thumb bilaterally, just like our previous patient, first patient. Rhombex negative, mild fingernose involved to the left hand, tandem walking defective. So the picture was something like high cervical myelopathy, just like the first patient. I will skip all these things. Now this is the MRI of the cervical spine. You see what is happening here. Here he has got again extradural CSF collection. Here you can clearly make out that disc bulges abutting the dura and tearing the dura. It is encroaching into the dural space, into the spinal cord itself. And there is a spinal cord atrophy, again pointing to a long-standing ischemia. And there is hyperintensity within the cord, in the region of anterior constant. This patient had no element finding in the upper or lower limb, only pain with severe backache, but he had severe cord atrophy which into ischemia. Again, as Bindu was telling, probably to the chronic long-standing ischemia is causing this presentation. I'll show the axial cut again. This is the dural collection. This is the abutting the disc of compressing of the dura. And you see the anterior ischemic changes in the same patient. And this is the extradural CSF collection. And the cord has gone on to atrophy. This is the compression by the disc. Cervical thoracic region as well as the lumbar region, just like our previous patient. It also confined only to the ventral part, extensively anteriorly extended collection. And he's also got anticonceptive hyperintensity, but he did not have element wasting and weakness. So possibly he has got ischemia. The same pathophysiology is causing this patient's anticonceptive hyperintensity. But he had a severe back pain and burning pain by which he came. His MRI also showed only the infarct or no any evidence of intracranial hypotension. Okay, now we can discuss the case. This again showing the contrast. Yeah. So both two cases are the same. One person with hemiatrophy, one person severe backache and burning pain on the back. Any questions?
That this
Sir,
band point.
Pardon?
Hello.
No, I did not hear you. Can you tell me once again?
hello, sir.
Yeah, please. Reggie.
Sir, seeing that first case,
Yeah.
Sir, I thought it is more likely to be due to mechanical compression because in the flexion as well as the extension views, it is very clear that the CSF space was significantly compromised and the hyperintensity almost occurred at exactly that same spot. So if it was ischemia, like what sir was telling, it should have been, if it was a generalized ischemia or it was involving the anterior spinal artery, it would have been at least more extensive, or it would have been more in the lower part of the cord. But here, the compression site and the site of hyperintensity are almost at the same level. So is it not likely that the mechanism may be more of compression rather than ischemia?
Yeah, the problem is if it's a compression, why it the lesion is hyperintensity is confined only to the anterior concept. There is also anterior part of the cord which should become effect induced, but that is not compressed, that's not affected. So here it is selective involvement of the anterior hyperintensity indicate that is alone can be affected. If it's anterior compression directly on the cord, we expect hyperintensity in the anterior white column also. The second case, the tear was much below, and the compression was much below, the hyperintensity was much above. Again, pointing to that it is not the direct compression which is causing it, probably compression causing to the secondary ischemic changes in the cord. Because the hyperintensity is confined only to that.
Localized to areas which are totally away from that site of compression.
And that can occur with ischemia. That's the one which can occur with ischemia. The second case. The first case, it corresponds with the level of that the CS. Again, it's not exactly at the level because the so-called bulge and compression was at C2, C3 level. The hyperintensity was lower. I can show that picture. Yeah, just 1 minute. I'll just tell you something. This is the area of hyperintensity, but this is CSF collection is above that, and the compression what we observed was here in this level C2, C3. Here is much below that level.
Sir, in the second case, in spite of such a severe cervical cord atrophy, he doesn't present with any significant motor deficits or weakness.
Yeah, his only combined was pain, and the only objective finding was impaired posterior column of the little finger. He has no weakness, ataxia. He can walk normally. I did not show the video normally. So that is very funny in cord lesions. In chronic compressions, the cord may be in chronic. I have seen case of Atlantic dislocation where the cord is narrowed down to a thread-like diameter, only thread, but patient walking normally. So this is something in neurology which you can understand because of the adaptability or plasticity. I don't know what to call that. I have seen like that. The cord is like a thread, but patient is walking about normally in chronic Atlantic, but never in acute compression. It's only chronic slow compression that does that. Whatever remaining fibers are there that get re-energized or plasticity develops there to function properly.
Sir, is the Neurology still continuing, sir? Can we say based on the MRI, sir?
There is only whether it is continuing or not, we do not know. See, we know that there's a dural leak. There is a CSF. Otherwise, why should CSF occur there? I mean, like that for 6 years.
So if you do a CSF cystanogram, CT cystanogram, just like we do in intracranial hypotension, so will we be able to localize that site of leak much better?
In fact, that is the ideal thing we should do. We should do a dynamic myelogram. Dynamic contrast myelogram will show there is a state of leak. But in our hospital, that facility is not. Myelogram is hardly ever done now. We don't have a tilt table and all.
What treatment did you give for the first and the second case?
Same as this thing. System also we are introducing dye and showing the leak. System, yeah. I did not hear you. Please, can you repeat the question?
Sir, what treatment did you give in the first and the second cases?
That's the most difficult thing, because I consulted the neurosurgeon yesterday. Itself consulted this long discussion. He said, then I told him that there is a leak there, you have to patch them. Then he said, usually we do a posterior patch. Blood patch is posteriorly, we introduce blood, it will seep into that. Here he said that if you patch posteriorly, nothing will happen. You do not know the blood will enter into the anteriorly also. So ideally, I have to put a cannula in and take the cannula, introduce posterior through the introduce a cannula to the anterior space and then inject blood there. So that I am also a little hesitant, because such a procedure is a procedure. And if something happens, he's otherwise head and heart takes about mild weakness. If you make him quadriplegic, it will become worse. I was little hesitant. So what I thought that I will just put him on a collar to prevent further extension flexion, so that further trauma will not be there, and to give him adequate bed rest for some period of time. I do not know the real answer. Ideal answer will be do a surgery, but we have to weigh the risk and benefit ratio. Neurosurgeon also will hesitant to do. If it is posterior, he is very happy. Just like any other CSS and hypertension, he can have done many times here. Very happy, everyone do very well. It's absolutely one-day procedure, not one day, a few hours procedure, he can go back. But here it is an open surgery, and it has to be done under GA.
How much of blood is injected, sir, and at which level?
In fact, the blood quantity, I do not know. In fact, I send them to that, he does it. I think it's about 20-30 cc. I think that's what blood.
And sir, what treatment did you give for the second patient?
Second patient, I advised him absolute bed rest. He became comfortable and put some GABA pen and things like that. He was not willing for any surgery in that patient. He had a definite lesion in that tire.
Thank you very much, sir, for these two exciting answers.
Run doubts.
Yeah, please, Bindu.
Sir, one is this in the first case, sir. Suppose it postulate compressive myelopathy causing this anterior horn cell damage, then obviously the patient should have had lower limb spasticity and pyramidal signs, no, sir?
Exactly. We expect that to be the involvement. Correct. You're right. Usually, compression.
So in the absence of those findings in the lower limbs, we can still postulate as ischemia because that is a localized, isn't it?
Yeah. Moreover, even if sometimes compression may not produce pyramidal signs, if it is a signal change, it may be the site of compression. That's the point.
Sir,
Second case,
sometimes we see that. Hello, sir.
Yeah, please.
Sir, we see the disprolapse and we see the pancake sign more often little below that. So it may not be exactly corresponding to that level. No, sir.
Right.
When there is a compression.
But exactly below that means immediately below that, not few segments below that. Pancake is always disc is just below that is the hyper-enhancing lesion.
Sir, the blood patch they give around 10 to 15 ml at the site, and two people should be involved. One should take from the antecubital vein and should transfer immediately to the anesthetist, and he should inject, because it's a one person's a high chance of infection and all.
I don't get the second one. One person, 2% mean what?
One anesthetist should draw blood from the antecubital vein and immediately transfer the blood to the anesthetist who is injecting into the epidural space, 10 to 15 ml. So it's two people, sir, should involve.
This part I don't know the technical part. I send it to neurosurgeon, he does it for me.
Because recently I had a patient, and for that epidural patch was given, and patient improved fully. And this is how they did. And they specifically told that two people should be there. Otherwise, it's not a one people business and all. So that's it.
The things should be done immediately. That's all.
In the second case, that pain in the shoulder and neck is due to the Neural stretching, sir.
Yeah, due to the leak. Okay, just like our intracranial hypotension, where the headache is less on lying down, it's also less on lying down. It becomes less on lying down. But here it was so severe that he could not. He said the only position where it's comfortable was lying prone. He used to sleep prone only. We lie back again, he develops the pain.
Sir, in case 1, there is a dynamic compression. Does the blood have a patch help in those patients? Because they may again compression can occur again.
Yeah, that also I suggested to him to remove that particular compression. It's very difficult surgery to go that anterior. This is anterior, no posterior, not posterior. You have to do an extensive of that. Same thing, we can do a patch also. We can remove that compression and do the patch there. And if you remove that compression itself, that will alleviate the symptom itself. But it's not a simple surgery.
Sir, correct me if I'm wrong, sir. Sir, can we do a venous side angiography and see the draining site of the vein and can occlude that so that we can sort out this further damage of CSF collection there? Is it a CSF venous fistula?
No, not a CSF venous fistula. Okay. It's actually it's like when the CSF draining in the extradural space.
Okay, thanks.
Okay, shall we go to the next case or stop here?
Next case.
One more case, okay. The 10:30, the other program starts. The 60-year-old man, non-hypertensive, presently came with severe burning and aching pain from the back of the neck. Really, so this is the already shown here. Sorry. Notice numbness of dorsal aspect of left thumb. I think this I'll show it next time because this is a good case. When they take time, and I will show another small one. Long cases. Anyway, I'll show a short case. This I shown me yesterday at another meeting. The story of a 30-year-old woman was presented with episodic inability to open her mouth associated with severe pain over the right jaw for the last 1 year. This problem occurs especially while eating and speaking, and the tongue on the right is injured. The episodes last for minutes. This is a video of the patient.
തുറക്കാൻ ശ്രമിച്ചേ, പറ്റണില്ല. ഒന്നുകൂടെ അടച്ച മോളെ, നാക്ക് നീട്ട്. ഇപ്പൊ ഉണ്ട്. കൈവിട്.
You can see that the jaw is closed on the right side, unable to open it.
അടഞ്ഞു പോകുന്നു അല്ലേ? ഇപ്പോഴായിട്ടില്ല, വിട്ടിട്ടില്ല ഇപ്പോഴും. എത്ര നേരം നിൽക്കും അത്?
It's unable to speak because the jaw is closed on the time. What's the diagnosis of this patient? Yesterday I showed the other meeting who was attended there, don't answer. He was not present.
Spasm.
Spasm of which muscle?
Masseter.
Yeah, correct. What you said is correct. This is called a hemi-masticatory spasm. This condition, it is important to know this condition because the patient improves remarkably with common muscle pain. It's not a dystonia. Initially, in fact, without knowing it, I initially put her on Pacitine, which did not produce improvement. Subsequently, came to know about it and put him on Pacitine. Common muscle pain patient improved. So, hemi-masticatory spasm is a condition characterized by unilateral forceful contraction of one or more masticatory muscles. The involuntary muscle contraction consists of brief twitches and prolonged spasms occurring many times a day, either spontaneously and more often triggered by chewing and speaking. The tonic contraction may last up to a few minutes. They can be painful and prevent the patient from opening her mouth. It was thought that it could be due to the cross compression of the arterial loop, just like what you get in trigeminal neuralgia. But in 2 patients with hemi-masticatory spasm, surgical exploration failed to disclose anomalous vascular contacts along the intracranial roots or the distal course of the nerve. On the other DD, which always keep is the oromandibular dystonia, the jaw crossing dystonia. But here, the abnormal electrical activity in hemi-masticatory spasm distinguishes dystonia, whereas in hemi-masticatory spasm, there is high frequency motor discharge occurring during the spasm only. In dystonia, it occurs both in the agonist and antagonist simultaneously produce electrical activity. That's the point which you're telling. Then the other DD which you would keep is hemifacial spasm. Although hemi-masticated spasm closely resembles hemifacial spasm, electrophysiologically, the 2 disorders differ in many respects. First, involved muscles may become hypertrophied in hemi-masticated spasm, whereas hypertrophy of the muscles innervated by the hemifacial spasm does not occur. Second, spasm associated with hemi-masticated spasm may be very painful, whereas pain rarely occurs with hemifacial spasm. Third, there is no cross compression of the trigeminal nerve by a vessel. This is the posterior hypothesis. There is a compression of the temporomescetic nerve between this is the native venous sphenoid. This is the superior belly of lateral pterygoid. This is the foramen veil. When the nerve comes here, goes like that, get compressed here. And this is the nerve to the temporalis. This is the nerve to the masseter. So that get compressed there. That is the posterior hypothesis for the hemi-masticatory spasm. I'll show another case, or similar one. Look at this particular patient. He also gave the history of inability to open the jaw for the last 5 months. Look at the video here. See the muscle spasm going on? Can you see that? He cannot open it. He's trying to speak, but the jaw does not open. It's difficult to open the jaw. So this is the NDT, hemi-masticated spasm. Any questions?
So the second case is spasm or focal dystonia, sir?
No, it's a hemi-masticated spasm because they're all painful. Dystonia usually does not produce any pain. Sometimes they can produce, but as I told yesterday, usual dystonia which can produce one is spasmodic torticollis can sometimes produce pain. Rarely right wrist cramp. Other focal dystonias like fibrospasm, the other thing, laryngeal spasms, etc., are not painful.
Has anybody tried to do decompression of the temporomasseteric nerves?
Yeah. In fact, here I do not know, which I do not know that because they usually give, they respond very well to treatment. That is so, just like trigeminal neuralgia, they respond very well to treatment. This is only postulated hypothesis. I think somebody had tried. I vaguely remember that somebody has tried decompression. I do not know the result at all. Only I vaguely remember that.
Sir, Botox has got any role in this case, sir? Botox?
No, Botox can alleviate any spasm. This is episodic, no? So you can, unlike dystonia, this can respond treatment. Then why go for Botox? Dystonia Botox you can give. Any hyperactivity you can go for Botox that will alleviate it.
Sir, in the last case, the temporalis was also contracting. So,
yeah. That is, this nerve is supplying both temporalis as well as masseter here. And usually they both simultaneously get contracted, not only the masseter. Sometimes you may be only confined to the masseteric spasm only.
Is the same as a hemi-masticatory spasm, or is it a different?
Which one?
The hemi-masticatory spasm.
Well, same. The masticatory means that masticatory muscles are affected. That means including both temporalis and masseter. Usually we don't see the temporalis superficially. We see to see the masseter muscle contraction, but both muscles get contracted. If we palpate, you find the temporalis also get contracted. Then you say the posterior hypothesis here in the canal.
So if both are spasm, then why only hemi-masticatory spasm is having pain and hemi-facial not having?
No, that is difficult to explain. The dystonia also, there is an excessive contraction of agonist and antagonist till it's not painful. The site of origin and the pathophysiology is totally different.
And clinically,
if it is a nerve irritation, it can produce a pain. In trigeminal neuralgia, in hemi-masticatory spasm are all irritating the nerve. On the other hand, which contain the sensory fibers. On the other hand, dystonia is the extrapyramidal disease where there is irritation of the nerve per se. The pathway is either in the spinal cord or in the cortex, producing some loss of inhibitory mechanisms causing the spasm.
clinically, how do we differentiate whether agonist and antagonist are simultaneously active? Can we, or is it only by electrophysiology?
It's only by electrophysiology. Clinically, you can't differentiate. You can put the needle
agonist and antagonist.
Because once a President Day published a case of spinal cord disease producing dystonia, then how to prove was you put the needle both the agonist and antagonist and produce the simultaneous contraction. So
you need two needles simultaneously and
you need two channels. Two channel recording should be
there. So in trigeminal neuralgia, there is there's a vascular compression. Is there any compression in this case? Only a neuro in this case.
No, that's what only two surgery was surgically they explored in two cases that did not show any comment. I'll show here. So in two patients, surgical aspiration failed to disclose anomalous vascular contact.
Then that patient with intracranial hypotension, what is the reason for his fatigable weakness? Could we?
I have no idea, because there is some time back I showed a case of ALS, anti-Honsel disease, a typical ALS patient, presented with fatigable weakness, electrophysiology showing decremental response, and without response to neostigmine. This case I have shown some time back. I can show it next time if you want. So ALS is one condition which can present like myasthenia-like symptoms. Not only clinically, but electrophysiologically also.
So here in this case, that fatigability, can it be because the weakness was very mild and the patient was keeping it for some time, so there was automatically?
Exactly. It's mild, so it's mild, he gets fatigued, so he leaves it out. Then after some time, you have to again lift it up. So it's because of the fatigue only. The muscle get fatigued easily.
Very nice case, sir.
Okay, thank you. So we stop here. It's time for the next meeting.
Thank you, sir. Thank you very much.
Thank you very much, sir.
Yeah, okay. Thank you. Thank you all for your listening.
Thank you, sir.
Thank you.